Good morning, everybody. This session is purely video interactive session, and we'll be concentrating. There will not be any lectures, and you can stop in between whenever you want to have an interaction. You can stop in, or otherwise, this video is for about 50 minutes. There are about 5 faculty, but one person will be presenting the video, entire video, and you can direct your questions or queries to the concerned faculty. There are a lot of things which we leave to the staff, the OT staff or the other paramedics. But then we should be knowing certain things regarding the aseptic practices and what is happening in the OT. I know there are, I discussed with several of my fellow consultants what is the disinfectant that you use in the OT. They don't know because they have entrusted that to the paramedics. But then we should be aware of what is happening in our OT, because whatever happens, if God forbid, if you have an end off, the entire blame will come to the consultant only. You cannot blame the paramedic for that. So for that, it is always better that you know what is happening there, and then maybe you can guide them properly. And this session, we have introduced, we have included the disinfection in the OP, the disinfection in the OT, the hand hygiene, then the sterilization practices. All those things are purely video. There is no PowerPoint presentation. And I invite Dr. Rajiv to present that entire video, and then we can take questions from the floor. There is enough and more time for discussion. So if it is not interactive, then it is not useful. Thank you. Over to Dr. Rajiv Sasikumar.
Thank you, sir. We'll start playing the video. We'll cover the topic one by one. Lights. Front one.
Maybe we can switch on the lights at the back, but they switch off the light in the front.
Switch off the front one.
Front ones you can switch off. The back light you can switch on. Okay, yeah. Okay, then switch off all the lights.
With the light on, the video will not be very effective. Definitely we don't like to see a condition like this, an endophthalmitis. So we have certain principles. There are 7 rules for which we have to follow for sterile procedures. The scrub person functions within a sterile field. That is the first principle. Second is, sterile drapes are used to create a sterile field. All items used within a sterile field must be sterile. All items introduced onto a sterile field should be opened, dispensed, and transferred by the method that maintains sterility and integrity. A sterile field should be maintained and monitored constantly. All persons moving around, in and around, should do in a manner to maintain the sterile field. And finally, policies and procedures and maintaining a sterile field should be written, reviewed periodically. Now we have this panel here who is going to discuss everything about this aseptic techniques. And Dr. Nirmal is not come, right? Give him a call. Oh, okay. We'll start with OP disinfection procedures. This is a small eye hospital in Kerala. That's the OPD. That's the optical shop there. Just to give you an idea what this hospital is like. Now what we did is, we introduced phenolphthalein, which is a dye which we use to detect bribery. It's a clear solution, odorless solution into the hand of one of the patient. And we tried to trace him where all he went from this. The patient sit like this, see the hand where they hold. All these places are the site which has to be disinfected frequently. Look at the eye drops being instilled. Look at the lash touching all these things has to be taken care to prevent transmission of infection. And plus, we greet the patients like this. After that, we rub the eye like this. All this is going to spread infection. See, look at the patient right from the OPD. Phenolphthalein has reached here on either side of the air machine. In the OT, in the consultation room, slit lamp, chair where we were sitting, and the door handle which we never take care at all. It is the place which transmits most of the diseases. And the optical shop. So all these areas should be disinfected periodically with appropriate disinfectant solution and composition.
One point to note is the straight-on single unidirectional movement. You are coming to that, right?
Small music is there. Small volume. Keep. Small background. See, all these videos are self-explanatory. What?
So for the applanation and all, you can use 70% alcohol. But for the other one, it is better to go for a aldehyde-based compound. There are a lot of chemicals available, like bacillocid special, all those things, 0.5%. Aldasan is available, lysoformin is available. So I mean, these are all. I don't have any proper this financial interest in it, but you can go for any good disinfectant in the lowest 0.5%.
Is used. After that, you have to clean with saline, because they will get deposits on the surface which can be used on the patient. After cleaning with the chemicals, it is better to clean with saline also. No, whichever is going to come in contact with the patient, like applanation.
Sir, for applanation and scan, B scan, A scan probes and all, contact lens solution is very good option. Instead of alcohol, straight away use your contact lens solution, take it in a small gauze, wipe it, clean. It's not going to harm your cornea after that. bucket inside another bucket. We can remove it and then destroy the tip and dispose it off. It's better to disinfect before we discard it. That is the first topic. Now we are going to the second topic, is the hand hygiene. From a relatively clean patient, not the scrubbed person, or just a person entering into the OP.
what may happen is the transient flora on the skin surface will actually come out and it will actually cause more problems. That is only to the nails.
Having washed, you should dry. questions on that? That's the hand hygiene. Briefly, because everything is 10 minutes each.
Betadine for hand scrubbing with water.
No, chlorhexidine and betadine give the same effect, but chlorhexidine, one advantage is that it will give cumulative effect. The effect lasts more with chlorhexidine.
Surface action of betadine takes 3 minutes to come, whereas chlorhexidine in 2 minutes it will start acting.
So you mean it is superior in all aspects?
Chlorhexidine is better, but the allergic property of chlorhexidine is more.
like to
But,
ask
yeah.
Dr. Rajiv
Yes.
one question. Suppose you are a high volume surgeon, you have 10, 15 cases per day. Between each case, do you de-gown, wear a fresh gown, or just change the gloves, and
It
or you
depends.
re-scrub between each
Yeah.
case?
It has been recommended by the AIOS recommendation itself. Up to 3 to 4 cases, you can wear the same gown. But you'll have to change your glove for
No
it.
scrubbing again.
No scrubbing is needed.
Second thing I wanted to ask you, I don't know if this is the right time or not.
Yeah.
Suppose if you operate upon a case of HIV or a hepatitis B, how do you sterilize your instruments and the phaco tubings? How do you do that?
So that is where this universal precaution comes. You don't segregate between a HIV patient or a HPSAG patient or a normal patient. For all patients, you do the same procedure. But of course, if you know that this patient has got a HIV or a hepatitis B, then you take extra precaution. But then the sterilization of all equipments, it should be autoclave. It should be high-level disinfection.
See, the point what he wants to convey is every patient is HIV.
Unless otherwise proved.
Unless otherwise proved.
No,
And
do
if
you keep the instruments in basolate solution?
No
for some-
No
chemical disinfection. No
no,
chemical
no.
disinfection for ophthalmology. Nothing. No Sidex, no formalin solution, nothing.
Because there is no optimization. You cannot say this is sterile after that because there is no indicator for it.
And even
Some people were telling me ki you have to discard the phaco tubings. Is it true, or
no.
can we sterilize them?
Phaco tubings you can resterilize because it is autoclavable. So if you can autoclave it, then that is sterile.
Okay. Thank you. Thank you.
Can I add up a few things? Consider every patient as infectious.
Yes, sir.
Consider every blood and body fluid as infectious. So in between cleaning is the most important aspect.
Welcome, Dr. Nirmal.
In between cleaning will be the key.
Yes.
So actually the current concept in NABH also there is nothing called septic OT. If a HEPA system and your in between cases are cleaned, nothing will happen. Nothing will happen. But of course our loads are too much. That is why we are little bothered about all these things.
Intraoperatively, some things that we have to do is, usually the HIV, HPSAG, even though we will not segregate, will be kept the last. The nurse, there are some special, protective wear that you can use, disposable wear that you can use. And the after the theatre is over, all the waste that comes out of it is in a segregated bag. Usually that is not added with the other patient's wastes. And then all the disposables, if they can be disposed, can be disposed. Otherwise, maybe autoclave or double autoclave, I don't know, some people may do
There's
that.
a thing called
Sharps,
double
we have to be very
autoclave.
clear about sharps. Don't give the sharps like this. It has to be put on, there can be an intermediate table into which it can be put.
Pardon? Phaco tubes, it has to be sterilized, autoclaved. Dr. Chitra, you wanted to ask something.
HIV, yes.
Exactly.
How many of us are really testing for hepatitis B? Because hepatitis B transmission is a very real prospect in surgery, not HIV. HIV has never been known to be transmitted through surgery. So how many of us do we need to test for H?
Now the
Not
standard.
for phaco, but for all those where you would.
Now the standard pre-op investigations include all these things, ma'am.
You should, right?
Yeah, HIV, HPSAG, and even hepatitis C. All these things are tested first. No. If the glove is proper, if the glove is good, quality of the glove is good, so only one glove is enough.
The problem is about needle prick.
Needle prick
If
and
there's needle prick, double glove is not going to protect.
we have Dr. Nirmal, he is NABH assessee. So you have any doubt with NABH, you can ask him also.
Thank you, Rajiv. Just add to this, there is no mandatory requirement for HIV testing or HPSAG testing. So you need to counsel the patient before taking any test, but particularly with reference to HIV testing. So please don't do mandatory testing. It is a crime under the NACO guidelines. First. Second thing, testing for our own self. It is mandatory when you are employing a healthcare worker, particularly working in critical areas, you do a pre-medical examination for HPSAG also. And annually, if there are food handlers or operation theatre workers, they have to undergo a medical checkup. This is a requirement for the safety of the hospital as well as the healthcare worker. So
Yeah.
HbA1c testing has to be done annually, and for surgeons it is mandatory that you have a vaccination also.
Just adding up to what Dr. Nirmal is telling. All healthcare workers, irrespective of whether they are handlers or they are surgeons, need to be vaccinated with hepatitis B. That is more safer than testing every patient as a positive or negative case.
Excuse me, sir.
Yeah.
You just showed that it's AquaGuard water that is used
Yes,
for.
it can be used.
Can be used or
Can be used.
No, the final wash should be with filtered water, either AquaGuard or boiled and cooled water.
AquaGuard can be used.
where I operate, we don't have the AquaGuard, so the last wash I do is with saline bottle. That
Sterile saline. That's
Sterile.
okay. That's good.
It's better to do with water than saline. You know, the remnants of your saline will be there, and that will deactivate the disinfectant you're going to apply again.
And even it's not safe for the skin also. If you have
It's
got
not safe
15
for the skin
cases
also.
with salt, then
Use boiled cooled water is enough.
boiled cooled water.
So better not to use saline. Shall we move on? Because
Yeah, sure. Switch off the lights, please.
where we used to operate in a condition like this. So much. Those days, this is supposed to be modern theater with TV inside. You're watching. Look at the accumulation of dust there. The volume, please. Little. Every important. But you're going to cover him. You're going to drape him.
Madam,
No. That is
during
you-
intravitreal injections in the US initially, the incidence of endophthalmitis was very high. They never used to wear a mask, and they used to talk to the patient while they were injecting. And the high incidence of endophthalmitis was basically reported because of that particular thing. And they corrected it, and the end of rate came down to 0.01.
No, madam is asking why the patient is not wearing mask. They actually, see, when you start wearing mask in the initial days, you feel very uncomfortable. Imagine a patient coming for a cataract surgery with a mask.
No, and during the surgical procedure, it only we require that barrier. Before the surgical procedure, that is not required. During the surgical procedure, that
Whether the patient's mouth is covered or nose is uncovered, or anesthetist nose is uncovered, half the anesthetist, not even half, even almost all the anesthetists wear their mask only for the mouth. So I used to keep on telling our anesthetists, mask is meant to cover the nose also. So even the nose is not sterile, so you need to educate the anesthetist also. But I think over a period of time this is picking up. Even in last anesthetist conference we had a session on infection control, and this point was highlighted, and almost all the anesthetists agreed on this, that this is a common practice. that they will correct this common practice. So we need to put mask even for patients also.
Handling doors with your glove. He's asking what.
Pardon? No, this is just different solutions containing the glutaraldehyde combination. This is an HD specialist for hand disinfectant. It is a
to the second bucket, rinse again so that you get the end of that topic. Surface disinfectant.
No, actually, we just showed that fogger machine. Actually, fogging is not recommended, not needed in the OT. People used to do this fumigation also. Actually, that is also not necessary. Meticulous wiping of all the surfaces of the theatre is enough. And that can be done up to our arm's length every day. That if you have got surgery every day, that can be done at the end of the day. And weekly cleaning only at the end of the week. Weekly cleaning, you can include the sealing, all those areas. Otherwise, you need to clean only up to the arm's length.
If you are commencing an OT, at that time fogging is required or not?
No. Fogging is not required.
While commencing also? Like
Yeah. Because see, if your other protocol, if you are cleaning this disinfection of the surfaces, as we have shown, if that is done every day, then the morning of the day, you don't have to fog it.
No, he's asking about a new OT being opened for the first time.
No, that is different. That is entirely, when you are building a new OT and then starting it, it's a couple of weeks it will take. You'll have to clean it repeatedly, take 3 cultures, and all those 3 cultures should be negative. That's a different thing.
In our setups, when patients and the staff walks in, a lot of aerosol is generated and it is hanging around in the theatre room. So how won't a fogging not help? Fogging will obviously cause the aerosol to get neutralized.
Most of us are not having HEPAs. We are having unit installed.
Exactly.
Most of us.
No, fogging or fumigation will help only for the first 30 minutes. So if a team is operating, after 30 to 45 minutes, the air quality changes with your exhaled and inhaled air, as well as the debris given out by the surgical team as well as from the patient's skin. So this is a reality. That's the reason why ventilation standards are coming up. So you need to properly ventilate the operating room. There was a question about commissioning a new theatre. Fogging is allowed for the first 3 times, But once you install HEPA filter, please do not use fogging or fumigation, because these aerosols and particulate matter of the formalin or any other chemical use go and block the HEPA filters. So the efficiency comes down and the filter may not work to its validated arrangement.
So while commencing, the fogging is also done through AHU without HEPA filter?
Yes. So HEPA filter should be the last to go into a new theatre. Now air changes depends on the type of your operation theatre. If it is ophthalmic theatre, 15 to 20 is the recommended. But if your volume of operation is very high, you can increase the air changes. It cannot be fixed. It has to be dynamic. Yes, there is no controversy at all. Air pressure ventilation is mandatory. HEPA filter for general operations like your phaco surgery, so where the opening is very, very minimal, in that case HEPA filter which reduces your particulate count to 0.03 may not be needed. Okay, but generally operation theatre standards require that HEPA filter is mandatory. So basically you filter the air in two places. One is when you have air handling units, what is called as pre-filter. So many of the vendors now use two filters within air handling unit. One, a larger pore filter close to the air handling units. The next one, a smaller filter next to that. So most of the air is filtered at this level, pre-filter mechanism. So we do advocate a good pre-filter mechanism, single or double, and then HEPA filter is necessary and it's recommended, but it's not mandatory because the cost is very high. But even now the cost has really come down because you can reuse your HEPA filter. Some cleaning methods are coming up, automated cleaning methods to clean HEPA filter. In that case, cost will drastically come down, and maybe when we raise the standards, HEPA filter will become mandatory. There is no relaxation as such. So there are two standards. One is the entry level certification standards, where it's a entry level. As the name suggests, it's an entry level. You are entering the accreditation system. There we don't want to exclude hospital based only on this air handling unit and laminar flow. So there we accept any operation theatre with good process control of sterilization mechanisms. So there we do accept split AC. But we want to raise the bar to national or international standards. In that case, laminar airflow would be mandatory.
There are some wall-mounted units containing UV light and HEPA filter. Will it suffice?
No, sir. UV light again is occupational hazard. It's not recommended.
There is another thing called a fan filter unit. I think you will be mentioning that FFU. That is just a fan-powered HEPA filter. It just gives filtered air, and it won't maintain positive pressure. It won't maintain other parameters or control of humidity, or nothing is there. It just gives filtered air, and we don't know the throw of that unit. So maybe you'll have to keep it at the head end of the table, very close. Maybe within 2 feet you'll have to keep it. Otherwise you will not know whether it is giving that clean air in that operating field. Actually,
sir, many vendors sell this unit to ophthalmologists that it has all the 6 mechanism of air filtration, but it's not validated. So initially when they give, please, if at all if you want to buy, ask for validation, and also ask them to install it properly and then give validation again. Because many of this filtering mechanisms do not work beyond 3 months. It gets clogged, and after that it is just a blower. So it is not a filtering unit.
Sir, how frequently you require a validation?
HEPA every year is mandatory. Inspection and maintenance at 6 months is recommended generally. Depends on the volume.
Sir, I would like to know that should we have something like this false ceiling in the OT, or it should be bare like the cement ceiling only?
It all depends upon your financial capability. Say a concrete wall is good enough. Concrete wall is, but if you want to install a VLF, vertical laminar flow, you need a false ceiling. If you are going for a false ceiling, that should be airtight. There is no need, there is no, what is it?
We should not put lights on these.
You can put lights, but the concealed lights are available.
Yeah.
It should be airtight.
Okay.
Because the space above is, you don't know what is happening inside.
Yeah.
So that has to be airtight, and for that you will have to go for a stainless steel or a aluminum composite panel. That is very costly.
No
the stainless
gypsum
steel is very
no
costly.
gypsum board.
No gypsum board.
No gypsum board.
Moist
No gypsum board, and even PVC is not good. ACP also is, I mean, it is better than gypsum, but the best is stainless steel.
What is this? Because stainless steel will be very expensive. Most
Very
of us may
expensive.
not be
Very
able to
expensive.
afford it.
That is why you don't need all this false ceiling. You can go for the concrete ceiling, but you'll have to coat it with antifungal paint, polyurethane paint.
No, but what about the HEPA filter with
If you
laminate?
want to go for a HEPA filter, then you need a false ceiling. Otherwise, you'll have to open the roof.
Anything other than stainless steel that can be used, which may be affordable?
No. See, that is a compromise. ACP is a compromise.
Composite panel. No. Epoxy is different.
No, antifungal.
Yeah.
Yeah, you can use epoxy also.
Sir, one thing, sir, like I come here for say 5-6 days. I had some repair done in my OT because the OT is remaining closed for this time. I'll go and again I'll start operating from Monday onwards. So what are the precautions that how many times should we fumigate, should we clean it or do something before that so that it is ready by Monday? Because like you told, it will take 15 days for a new OT to start. So if I'm coming for a conference or doing a small repair, I can't wait for 15 days for the OT to get ready. What should be done?
I think it has to be taken in its proper overview of sterilization principles. If you are closing your theatre also, if you are not operating for 6 days also, your staff has to maintain the theatre. A daily mopping and cleaning is essential. This is mandatory.
Now, mopping clinic twice or thrice before the OT should be enough?
Yes. Daily mopping. See, please understand, I think you are confusing between commissioning theatre and regular maintenance.
No, I'm not talking about regular maintenance. I'm getting some repairs done when I'm away.
Yeah. If you are doing any construction activity or repair activity in your unit, whether it's carpentry, plumbing or even masonry work, you need to do a fogging and follow the same principle as that of commissioning a new theatre. So so don't bother about 15 days or 20 days. Your culture report, the two culture report has to be negative.
Thank you.
We will run with the video because we've got only half an hour.
questions on that?
Yes, sir. You showed all these needle holders and forceps and they were being packed for autoclave. Can we use a hot air oven?
Hot air oven,
no.
you cannot use this because it will catch fire. Which one?
Packing like this, you just put in a tray and put it in hot air oven. Is it
Hot air oven, it will take long time.
Long time, and the temperature is very, very high.
It is very, very high.
The sharpness will.
No, it will spoil your instruments. The tip of the instrument will be spoiled. Again, the hot air oven is not properly validated. The temperature mechanism is not validated. So that's why it's been given up.
It's not being used at all in ophthalmology. Hot air
No, but is it okay for sterilization purpose?
No,
Because
dry-
I never
No,
put
it's
blades.
not
I always use
okay.
disposable blades. So
Dry
sharp
heat-
objects I never put there.
Dry heat is not a recommended way of sterilization.
That's the next topic actually.
I think we'll run the video and take the questions after that because we've got only 25 minutes left. Pardon? For drying the equipment? Just
Use
keep
your
it
hair dryer
overnight
also.
or hair dryer.
Use a hot air dryer are there or instrument dryers are there. No, when you have a get better in the air.
Hot. It's better not to use it.
No,
First
if
of
you
all,
are cleaning
the temperature
outside,
you
then
need
you
is
need to
about
worry about the
230
particulate
degrees.
matter and this aerosol
That
matter.
temperature, even metals will start melting, and it will distort your instruments.
So the advantage of autoclave is supersaturated steam. That is the thing which sterilizes articles. In dry heat it doesn't come. Latent heat, I mean the saturated steam, that gives best the sterilizing pressure, temperature, and all those things. So you need that
especially for our vitrectomy cutters and things. It should not be used. Should not be used because there is no validation for this. You don't know whether what is kept there is sterile or not. But as such, actually it's a very good sterilizing agent, but there is no validation. Pre-malignant also. Carcinogenic.
And another thing is that any instrument with lumen, we don't know whether the formalin is passing inside. So this is not at all acceptable. Maybe you can put that 20D lens.
For OPD, that is for just disinfecting, it's not for sterilizing. So these are the items which can go in and out of different sterilizers. Steam, almost everything except the low density polypropylene. Where formalin, everything can go, but it's not reliable. ETO, yes, it's a very reliable, but it's a very dangerous gas. You'll have to handle it very carefully. If any remnants of the ETO is there, task can occur. So you got to be very careful with it. Plasma, cloth, paper, and all cannot be put. It's a very expensive machine and it's very limited. Something like endotracheal tubes, all those things, which is very heat labile, can be you can use plasma for that. And very sharp instruments can be used so that the sharpness is maintained throughout. We come to the end of this presentation. Any questions can be taken?
I got about 10 minutes for discussion.
10 minutes more.
How relevant is using steam sterilizer for our phaco tubings? Because it won't penetrate.
Yeah.
No. If you
No.
the vacuum cycle comes in. PCD I showed, no?
Yeah.
That if it is passed, PCD passed, your tubing can be used.
How are we sure that the steam will penetrate the innermost coil?
That's why you need a vacuum cycle. You remove the complete air even from inside the tube and then introduce the steam. That's a cycle I showed you, no?
That is possible only with the horizontal.
Only, not only horizontal, even automated ones have all that.
What about the vertical one?
No, vertical ones, the vacuum cycle is not there. And there are in the vertical areas, it is not uniform. The steam comes from the top, so it may not reach to its fullest potential to the lower bin. So that's the reason why vertical autoclaves are not advisable. Horizontal autoclave with vacuum cycle, that is the most advisable, and you need not bother about steam reaching the inner part. Once the inner lumens through vacuum, all the water content moistures are removed, so steam can sterilize each and every surface it gets into contact.
Yes, Dr. Rajiv, you gave a very lucid talk. You covered almost everything. I just wanted to know, at what frequency will you take swabs from the OT?
Actually,
which stands in the court of law? What is the frequency? 7 days?
Any person say that.
I want to know from you learned people, what is the exact norms which we should follow swab culture from the OT, where from the OT and at what intervals?
Right. Microbiological surveillance is given up even by the microbiologists themselves. So no point in sticking to microbiological surveillance. Microbiological surveillance of OT is necessary only for few conditions. Only when we are commissioning a new theatre and when there are any repair works in the theatre, and third is in case of cluster infections. So if you get a cluster infections, in that case you need to investigate properly, and microbiological surveillance is part of the investigation. It is not the only investigation. So you need to see where the source of infection, and you need to check all your supply chain of all your consumables used. So it's an investigation, it's like a police investigation. So microbiological surveillance is relevant only in these three conditions. Routine surveillance is not necessary. What you need to follow is universal precautions, standard precautions of daily mopping and cleaning your operation theatres, weekly cleaning cycles, and surface mopping of all your equipments and tables, furnitures inside the OT, and following universal hand hygiene mechanism. That's it.
But I'd like to add one thing. Currently, NPCB says once in 2 weeks we need to take swabs. Once every fortnight.
That is for non-laminar theatres, non-air handling unit theatres.
That is why. So if there is a cluster, be it a paying or free case, this will be looked into. They will look at 2 years history, not just 2 weeks history. Many things will go into it. Probably in the next program we are talking about cluster.
We have a similar program at 2:30 in the same hall, so you can attend.
Yeah. But as it is, thank you.
Horizontal autoclaves, they are electricity run or gas run?
Electricity run.
The principle of horizontal is different from vertical. Yes.
We have double door horizontal autoclaves. One side you put the unsterile, goes into the storeroom where you can take the sterile. So it keeps it more unidirectional.
What is your recommendation for a small-time solo practitioner going to start his or her own practice? Because all these things, horizontal autoclave and laminar flow, is a huge cost involving things. So, for a standalone practitioner who is going to start, who is going to maintain, what are your recommendations?
First is the mindset. Don't think all these are too costly. You just need to understand the basic principles. The vendors try to increase the cost for their own interest, right? So whatever equipment or whatever space you are going to design, keep your basic requirement in mind and then design. So I think maybe the next session I'll cover about the design aspect. Buying the equipment, so it is an investment on your practice. See, almost 70% of your income is going to depend on your operation theatre. You are willing to spend 50 lakhs and 60 lakhs on phaco machine, but you don't want to invest for 3 lakhs for a horizontal autoclave. So you need to change your mindset rather than your going for cheaper. Please understand, whatever cheaper machines you buy, you are going to have a recurring cost. So it's better you invest on quality equipment right from the beginning rather than incurring recurring expenditure. So these are very, very important. Sterilization is absolute necessary. So go for a proper vendor. You select your vendor properly. Get experience, feedback from the other experienced owners. This is where they will help you. See the maintenance aspect of the machinery. See whether whatever the principles or training you can give it to your staff. All these are important rather than focusing only on the cost aspect.
Sir, if the instruments are sterilized in a horizontal autoclave, then how many hours it has to be used? Because
that's called the shelf life. Yes. It depends whether
See, the shelf life of a properly packed linen pack is about 1 week. 1 week linen pack.
If it is dry,
you pack it in cloth. That is 1 week. In that sealing pouch, if it is properly stored, not only autoclaved but properly stored, it can last up to 6 months to 1 year.
That's why that's the importance of.
So it all depends upon where it is stored. So the storage also is very important.
In a steel drum?
No, not in the steel drum. There is an open storage space with, actually it should have laminar hood and all. No. If you're using this stainless steel drum, actually that is not recommended nowadays. If you're using the stainless steel drum, if you're doing the surgery in a couple of days, you keep it inside the drum itself. Don't open it. You close the side flap and then keep it in the drum.
But most of the time they are wet.
It should not be wet. That means your autoclave is not proper.
Autoclave is not working properly.
See, if you have a proper autoclave, immediately after the cycle, that will take about 1.5 hours. One horizontal
If you
autoclave
open
cycle.
immediately, it will be wet.
See, after the autoclave cycle, once it cools down, you open it, you can use it immediately. That should be dry. If it is wet, that means your vacuum cycle is not proper.
You have to check your autoclave.
No, what I work in a...
Because it's a moist steam inside. Because water is there, it becomes steam. The steam is mixing with vapor. There's nothing called a vacuum at all there. What you can do is you can let out whatever air is there on top, but it's not 100%.
Actually, steam should be 97% dry. Only 3% moisture is allowed inside steam. In a vertical autoclave, it is all wet. It is not dry steam.
It should be changed. I am using that only. So should I change it?
No, that is not ideal. I mean, if you are not having any problem, maybe.
I'm asking for direct.
No, it should be changed. Horizontal autoclave with a vacuum cycle. Not all horizontal autoclaves have vacuum cycle. So you should have one horizontal autoclave. It will cost about 40,000 rupees more.
No,
the
this
vacuum cycle.
Horizontal with vacuum cycle, there are two types. Gravity shifting vacuum, that is, you send in steam inside and push the air outside by gravity. There is vacuum pump taking out. That's a little costlier, but that's safer than the gravity vacuum.
Now there is a gap.
Maybe about what is the size of horizontal?
No, horizontal autoclave comes in different
feet,
sizes.
6
The
feet.
one which can occupy 2 drum, 3 drum, like that.
Smaller sizes are available, sir.
Smaller sizes are available. Yeah,
three and a half.
3
and all
feet.
is
See,
available.
actually, 80 liter autoclave, the fully automatic 80 liter horizontal autoclave costs around 3 lakhs.
The autoclave should be specific for ophthalmic instrument?
No, nothing like that. Nothing like that.
In a general hospital?
No, general hospital, the autoclave, see, there is nothing specific for ophthalmology.
What I do at my place is horizontal autoclave is used in the evening because the technicians don't come in the morning.
Yeah.
So I re-autoclavate them in the morning. And
Not necessary.
Not
Not necessary. That is where the term of double autoclaving, there is no thing like double autoclaving.
Then from the horizontal it goes to vertical autoclave, and that's the reason we do it. Not required.
It's a wastage of
Sterile will become unsterile.
It's a wastage of resources, both time and energy, as
There's
well
nothing
as
called
electricity.
partial autoclave.
So double
Maybe
autoclave is basically a wastage.
It's something like boiling your egg with 50 degrees twice. It's not equivalent to 100% boiling.
I see.
It is the horizontal autoclave is done properly. If I'm it gets over by evening 5, and I'm operating next day at 8.
No problem.
No problem.
If it is removed from that, if the pack is or bin is dry, you can leave it and no. Or you open it the next day and use it. Leave it in the autoclave itself. If you are not using the autoclave for any other purpose.
So with that, I think the next session is about to start. Thank you very much, all the faculty members and all the delegates for the interaction. Thank you.